Trauma referral to cardiothoracic surgeon. Refer the patient to a cardiothoracic consultant. Hello, I am Omar, Esho, working with Mr. Mann. I'm calling to speak to Mr. Hamish, a cardiothoracic consultant, regarding one of the trauma patients. May I confirm whom I'm speaking with? Yes, it's me. Hi, Mr. Hamish. I'm calling to discuss a patient referral for a polytraumatized patient with findings of a widened mediastinum on chest X-ray. Summarize your case? A 45-year-old male involved in a motorcycle accident arrived with a Glasgow coma scale of 14, a pulse rate of 120 beats per minute, and a blood pressure of 100/80 millimeters of mercury. Upon examination, a swollen left thigh was noted. Chest X-ray revealed a widened mediastinum and bilateral hemothorax with a chest drain successfully draining 200 cubic centimeters of fresh blood. Unfortunately, a CT scan was delayed due to machine servicing for the next 3 hours. Further investigations indicated an absent psoas shadow on abdominal X-ray and a shaft fracture on femur X-ray. Blood results showed a hemoglobin level of 8.9 grams per deciliter and a pH of 7.32 with low bicarbonate levels. Additionally, the patient is a known diabetic. Fluid resuscitation was initiated with 4 liters of crystalloids and 6 units of blood were cross-matched pending transfusion. Why is this patient being referred? Due to the widening of the mediastinum. What does this widening suggest? Cardiac tamponade or aortic rupture. What's in the differential diagnosis? Cardiac tamponade. Aortic rupture. Aortic dissection. In traumatic aortic injury, which part is usually affected? The descending aorta. I see. Regarding management, what's the plan for the cervical spine and leg injuries? For the cervical spine, we'll provide support using a hard collar, and for the leg injury, we'll apply a Thomas splint. We've also started fluid resuscitation and blood cross-matching, but we're cautious about allowing the blood pressure to rise due to the risk of increased hemorrhage. What measures have been taken for the patient's blood pressure? Fluid resuscitation has been initiated, but we aim to maintain systolic blood pressure below 100 mmHg to prevent increased hemorrhage, permissive hypotension. Cross-matching for blood has also been performed. Potential sources of bleeding and hemorrhagic shock for this patient? Ruptured great vessel in the mediastinum. Abdominal bleeding. Thigh injury. What type of shock does the patient have? Hypovolemic shock, indicated by vital signs. Other potential causes of shock in this patient? Obstructive shock, possibly from cardiac tamponade. Cardiogenic shock if there's cardiac contusion from trauma. Why did the chest tube drain only 200 milliliters if major vessel injury is suspected? The chest tube is in the pleural cavity, whereas major vessels are located in the mediastinum. What is the definitive management for aortic injury? Open repair. Endovascular repair. What blood abnormalities are present in the patient? The patient exhibits low hemoglobin levels and metabolic acidosis. Why is the patient experiencing metabolic acidosis? Possible causes include a closed femur fracture leading to compartment syndrome, hemorrhagic shock, and the patient's diabetic condition, suggesting diabetic ketoacidosis as a potential cause. What additional investigations would you consider? Echo and ECG, Connecticut chest, abdomen, and pelvis with contrast confirm renal functions are normal. And CT brain, regarding the abdomen, what findings suggest further exploration? The absent psoas shadow on abdominal X-ray indicates a possible retroperitoneal collection, suggesting the need for exploratory laparotomy. What preparations will you make in the ambulance during the patient's transfer? Oxygen. Fluids. Initiate blood transfusion. CPR set. Extra chest tube, in case the existing one is blocked. Information and communication technology. If intubation is required during the transfer, who will perform it? The anesthetists. Thank you for the thorough update. Who will accompany the case? I'll be accompanied by one of our anesthesia or ICU colleagues. Excellent. Thank you, Dr. Omar, for the detailed information. Please proceed with the referral and keep me updated on the patient's progress. Thank you, Mr. Hamish. I'll ensure to provide timely updates. Goodbye. Goodbye.